Hello students, welcome to the Microbiology MCQs of the INI-CET November 23. So to analyze the questions, I would say in microbiology, the questions were of moderate difficulty level. There were about 4 to 5 image-based MCQs. There were a couple of bouncers, but most of the questions asked in microbiology were from previously asked topics, like, the question on Eschar, question on herpes viruses, mucormycosis, action of bacterial toxins, right? So let's start out by finding out the topics that were asked. So there were about 17 to 18 questions in microbiology, right? So to start out, the questions, we had an image-based question on superantigen, image-based question on diphtheria toxin, mode of action, image-based question on Eschar. Then we had a question on virulence factors of listeria. We had a question of COVID patient with mucormycosis. Then we had two questions from general microbiology. That is, they were asking about the genetic material, what kind of genetic material a particular organism has, and biosafety levels. Then we had many questions from viruses, teratogenic viruses, HIV, dengue. We had 3 questions on dengue virus, herpes simplex causing meningitis, then oral hairy leukoplakia, and the component of the HPV vaccine. Then we had 2 absolutely new questions. One was an image-based question on acanthamoeba, and the other was regarding stool mounts. Okay, so let's start out with the first question. Which of the following toxin acts by the mechanism shown below? Right, so if you see this image, you can see the antigen presenting cell is presenting in the groove of the MHC class 2 a peptide in its groove to the T cell. Since it is presenting the peptide in MHC class 2, obviously should be a helper T cell. Okay, but what we have been asked is regarding this antigen, which is not being presented in the antigen presenting groove. Now we know that superantigens are special peptides, medium-sized peptides, which can directly bind to the MHC class 2 at a site lateral from the usual antigen presenting groove and need recognition just by the V beta part of the T cell receptor, right? So the answer to this arrowed structure is a superantigen. And amongst the options, Clostridium difficile exotoxin, diphtheria toxin, botulinum toxin, and streptococcal pyrogenic exotoxin, the one which is a superantigen is the option D. Okay, so here is a picture which is showing us regarding the action of, rather, how a normal peptide is presented in the groove of the MHC class 2 of the antigen presenting cell, and it is being recognized by both the V alpha and the V beta part of the T cell receptor. Okay, but here we have the superantigen, which does not need processing by the antigen presenting cell. It binds to a site lateral to the usual antigen presenting groove, needs to be recognized just by the V beta part of the T cell receptor, as a result of which there is a massive activation of T cells. Many T cells getting activated, secreting cytokine, and that is what creates the cytokine storm that precipitates toxic shock syndrome. Next question, the toxin produced by which of the following organism acts by the mechanism shown in the image below? Okay, so here you can see in this image, the action is preventing protein synthesis via elongation factor 2. Okay, so we know there are 4 toxins which act by inhibiting protein synthesis. Let's find out our answer. Vibrio cholerae, that acts by increasing cyclic AMP. Corynebacterium diphtheriae, yes, this acts via elongation factor 2, inhibits elongation factor 2 and thereby inhibits protein synthesis. Bacillus anthracis, its anthrax toxin acts by increasing cyclic AMP. And Shigella dysentery type 1 to be more specific, which produces the Shiga toxin. This also inhibits protein synthesis, but it does not act via elongation factor 2. It acts via its inhibition of the 60S ribosome. Okay, ribosomal subunit. Now let's quickly recap the 4 toxins which act by inhibiting protein synthesis. 2 toxins act via elongation factor 2. These are diphtheria toxin and exotoxin A of Pseudomonas aeruginosa, and via 60S ribosomal subunit, these are Shiga toxin, which is produced by Shigella dysentery type 1, and the Shiga-like toxin, which is produced by enterohemorrhagic E. coli. Okay, it's also called as the verocytotoxin. Okay. A farmer presented with fever and a skin lesion as shown in the image below. Blood investigations revealed creatinine levels of 1.4 milligram per deciliter and platelet levels of 86,000 cells per cubic millimeter. What is the likely diagnosis? Okay, so this image, it is showing us a black necrotic scar in the middle. So what is this? It is eschar. All right, so let's find out what could be the likely cause. Anthrax, yes, it is associated with, like cutaneous anthrax is associated with the formation of an eschar. Leptospirosis and brucellosis, neither of them is the answer because they don't have eschar-like lesion. Yes, scrub typhus could be our answer. So out of these, which is the one which is our answer here? Please note there are certain levels mentioned out here. Creatinine levels are elevated and the patient has thrombocytopenia. So the answer here is scrub typhus. Scrub typhus, the most common rickettsial disease in our country, is a very, very important disease to memorize for our exams. Okay, scrub typhus, also called as shigerosis, caused by Orientia, transmitted by the sugars of trombiculate mites. It's very commonly asked, and a very important complication of scrub typhus is that the patient could have renal failure. This is what is mentioned here. Patient could also have disseminated intravascular coagulation because of thrombocytopenia. Both these complications are mentioned. Apart from that, scrub typhus also causes meningoencephalitis, and it can also cause pulmonary failure. Okay. So these four complications you must remember regarding scrub typhus. Okay. So our answer to this question is option D. Cutaneous anthrax or malignant pustule never leads to these kinds of complications like are mentioned out here. Okay. So eschar, kindly remember that the following conditions are associated with eschar formation. One is brown recluse spider bite. Next is cutaneous anthrax or Hyde Porter's disease or malignant pustule. Next is the spotted fever rickettsial diseases. Also, except for Rocky Mountain spotted fever. Then we have scrub typhus. And finally, ulceroglandular tularemia. Okay, these are associated with eschar formation. A 25-year-old patient presented with a 3-day history of fever, headache, myalgias, and retroorbital pain with no signs of bleeding. On examination, a maculopapular rash is seen, which is the next appropriate step in management of this patient. Okay, this question and the next two questions were regarding dengue. And for them, we need to remember the WHO guidelines for diagnosis of dengue, severe dengue, and also regarding the actual diagnosis in the laboratory. Okay, so before we read the options, let's do these guidelines. A patient should be suspected of having probable dengue if the patient lives in or has traveled to dengue endemic area and the patient has fever with two of the following: nausea and vomiting, rash, myalgias or arthralgias, tourniquet test is positive, or leukopenia. So in this patient has a rash, has myalgias along with fever. Our criteria is fulfilled. So we should be suspecting this patient of suffering with dengue. Okay. So that's what we are going to look for. So either of these, option A or option D, should be, are in our minds for marking our answer. But this patient has a 3-day history. IgM ELISA for antibodies against dengue will become positive after 3 days. So we are going to detect the NS1 antigen in the patient's blood for diagnosis of this dengue. Okay, so our answer to this is option A. I will reiterate this when we have our third question in dengue. Okay. Moving on, what to the next guidelines of dengue, WHO. Warning signs of dengue: when the patient has persistent vomiting, severe abdominal pain, fluid accumulation, mucosal bleeding, difficulty breathing, lethargy and restlessness, postural hypotension, liver enlargement, progressive increase in hematocrit, and thrombocytopenia. All these are the warning signs of dengue. Okay. And finally, we have the WHO guidelines to tell us this is a patient with severe dengue. So when the patient has severe plasma leakage leading to shock or fluid accumulation with respiratory distress, fluid accumulation in the pleural cavity, the patient has severe bleeding, or the patient has evidence of severe organ impairment in the form of elevated liver enzymes, more than 1,000 international units per liter, or patient has impaired consciousness, or the patient has evidence of cardiac impairment. Okay, so these you have to memorize: probable dengue, warning signs of dengue, and severe dengue. Okay, next question. A 13-year-old girl presented with fever and retroorbital pain for the last 2 days. The tourniquet test and NS1 antigen test are positive. Which of the following features is considered as a criterion for a severe form of this disease? So we just did the criteria. Amongst them, what was our answer? Liver enzymes are elevated, more than 1,000 international units per liter. The rest of them are mostly criteria, warning signs of dengue. You suspect dengue in a patient who presented with a 3-day history of fever, headache, and retroorbital pain. Blood investigations revealed hemoglobin of 14, WBC's 4,000, so patient has low leukopenia. Platelet counts are reduced, markedly reduced. Which of the following tests will not be useful in confirming the diagnosis of this condition? NS1 antigen detection, viral culture and isolation in Aedes albopictus C636 cell line, RT-PCR, or IgM ELISA. Okay, so here what is our answer? Not useful, because this patient has a 3-day history. Okay, so let's quickly go through what are the important things we're going to remember regarding diagnosis of dengue. When the patient has symptoms less than or equal to 3 days, then we are going to use either viral culture, viral isolation in those cell lines, Aedes albopictus C6/36 cell lines, or we can detect the NS1 antigen in the patient's serum, the by ELISA, or we can do RT-PCR. Okay, but beyond, after 3 days, even antibodies will start to appear, so we can detect them by MAC ELISA. So if at that time, beyond 3 days, if it is MAC ELISA is still negative, then we can look for again NS1 antigen detection. Okay, the CDC says that NS1 can be used for diagnosis up to 7 days. Though yes, it is positive in the patient's blood even up to 12 days, but CDC recommendation says you can use this test only up to 7 days. Okay, beyond that, of course, antibodies will definitely appear in the patient's blood. An 18-month-old child presented with fever, irritability, neck stiffness, and Kernick sign is positive. The mother gives a history of painful genital ulcers a year ago, which had resolved spontaneously. What is the most likely causative agent? So we have here a 1.5-year-old child with symptoms of meningitis, and what is specifically mentioned is that the mother has a history of painful genital ulcers. So that is why we have to correlate both these mentioned things and then arrive at the probable etiology of the meningitis. So HSV2, CMV, HPV, varicella zoster virus. Which of them would be causing painful genital ulcers? Obviously, it would be herpes simplex virus 2. So most likely, this female had HSV infection. Okay, it could be a symptomatic or an asymptomatic infection during the delivery of the child. The child got the infection from the infected maternal tract and did not manifest at that time. HSV2 became latent in the neurons of sensory ganglion, and later 1.5 years later presented with symptoms of meningitis. Okay. Otherwise, if these painful genital ulcers had not been mentioned, then we would have thought of other causes of meningitis in the child, more likely enteroviruses. But because this is mentioned, painful genital ulcers, our answer to this question is HSV2. Okay. A quick recap. We're going to remember that there are just two causes of painful genital ulcers. One is Haemophilus ducreyi, which causes soft sore or chancroid, and genital herpes, which is because of HSV2 more often than HSV1. Okay, so that is the cause, the etiology in this case. An immunocompromised patient presents with white corrugated plaque on the lateral border of the tongue that cannot be rubbed off. Which of the following is the causative agent? Candida, human herpes virus 8, HSV1, and Epstein-Barr virus. Okay, which one of them would lead to whitish lesions on the lateral border of the tongue? Can Candida lead to? Yes, it can lead to white, cheesy, cottage cheesy like material on the tongue, that is oral thrush, can manifest. But that is not the cause here, because what is typically seen in oral thrush is these, that material can be easily scraped off, leaving erythematous basis. Okay, but here it is saying that they cannot be rubbed off. So more likely the answer is oral hairy leukoplakia, which is caused by Epstein-Barr virus. What about HHV8? Yes, it can lead to lesions on the tongue. What does it cause? It causes Kaposi sarcoma, but these lesions would not be red, would not be white, they would be red in color. Okay, and HSV1, it can present as lesions on the tongue and the form of groups of painful vesicles. Okay, so our answer to this question is oral hairy leukoplakia. So that is our white corrugated lesions which cannot be scraped off, unlike oral thrush, which can be easily scraped off. The recombinant form of the vaccine to prevent cervical cancer has which of the following proteins? Okay, what is the recombinant form of this protein? So we have Cervarix or Gardasil. At present, the Gardasil vaccine is Gardasil 9. Okay, and what do these vaccines contain? They contain the L1 protein, which is the major capsid protein. This is very, very often asked in our exams, component of the Gardasil or the Cervarix vaccine to prevent cervical cancers. Okay, so if you look at this HPV genome, please see that there are two capsid proteins, L1 and L2, which are encoded by the late region. This is the late region of the genome. The early region of the genome encodes 6 proteins, which are non-structural proteins. Okay, so if we see the HPV genome, it is containing the early regions encoding 6 non-structural proteins, out of which E6 and E7. What are these? These are the oncoproteins. They inhibit the tumor suppressing proteins. Okay, so E6 inhibits the P53 protein and E7 inhibits the retinoblastoma proteins. Okay, but what is the component of the HPV vaccine is the L1, the major capsid protein. Which of the following organisms requires the use of reverse transcriptase in PCR for amplification of the genome? This is an indirect way of asking what kind of genome does the virus have. Which of the following has an RNA genome? In normal PCR, one copy of DNA gets amplified into million copies of DNA. But when we want to amplify RNA, what we have to do is first convert the RNA into DNA. So for that, we will require reverse transcriptase enzyme, and then we will be able to amplify that DNA. Okay, so let's find out what is the answer. Parvovirus, this is a DNA virus. It has a single-stranded DNA genome. Adenovirus, DNA genome. CMV, all herpes viruses have DNA genome. Respiratory syncytial virus is a paramyxovirus. and paramyxoviruses have a RNA genome. Okay. So, very important, I would say, in virology, always remember the properties of the viruses, whether it is enveloped, non enveloped, what kind of genome does it have, where does it replicate. These things are important, and knowing the members of every virus family is equally important. That is how you will remember RSV belongs to paramyxoviruses, and all paramyxoviruses have an RNA genome. Okay. So that is our answer. We will require reverse transcriptase when we want to amplify its genome. Okay, so happy are the viruses which have a DNA genome, okay, which have a DNA genome, not double-stranded DNA genome. So which are these? These are herpes viruses. H stands for hepadinavirus, A stands for adenovirus, P stands for parvovirus, P stands for polyoma, P stands for papilloma, and finally the pox viruses. Happy viruses have a DNA genome. A COVID patient who was treated with steroids presented with a blood-tinged nasal discharge 3 weeks after recovery. The histopathological examination of the discharge showed the following findings. Which of the following organisms is likely to be involved? Okay, so this is an image-based question. It's a very, very easy question now. COVID patient who has most likely been treated with high dose of steroids is mentioned here, and has now come with blood-tinged nasal discharge. What are we seeing on microscopy of this discharge? We are seeing broad ribbon-like hyphae. Broad ribbon-like hyphae, and these are showing 90 degrees or obtuse angled branching. Okay, very well appreciated out here. Aseptate hyphae, broad ribbon-like aseptate hyphae. Okay, so diagnosis here is mucormycosis, and amongst the options, the member of mucorales is mucor. Okay. Which of the following organisms exhibits pathogenesis by cell-to-cell transfer facilitated by actin filaments, eliminating the need for extracellular transport? This is a relatively new question. Which of the following acts via it spreads from cell to cell via facilitating, activating actin polymerization? The answer to this is Listeria monocytogenes. Okay, when we study the virulence factors of Listeria, we need to remember three of them. One thing which is going to help it enter into the host cell, and those are internalin proteins. Then once it is enclosed in an endosome, how is it going to get released from the endosome? It has a special virulence factor called as listeriolysin O. Okay, and once outside the endosome, it causes actin polymerization by a special protein called as ACT-A. Okay. And by actin polymerization, it spreads from cell to cell, eliminating the need for extracellular transport. So remember, there are three organisms, three of them for you to remember: Listeria, enteroinvasive E. coli, and Shigella. These are able to spread from cell to cell by actin polymerization. Okay. EIEC and Shigella have the same pathogenesis. They are sampled by the M cells, okay, and they are pinocytosed. Then they are transferred to the underlying macrophages. Macrophages they undergo apoptosis by, once they are passed on these Shigella or enteroinvasive E. coli. And once they are extracellular, they will attach to the basolateral aspect of the GI mucosa, colonic mucosa, become intracellular by actin polymerization, and then they spread from cell to cell, similarly by actin polymerization. Which of the following helps the human immunodeficiency virus to penetrate into the host cell? GP120, GP41, CCR5, and CXCR4. We have two envelope proteins. It is GP120, which binds to the CD4 receptor on the host cell to become intracellular. Okay, so our answer is option A. So quick recap. when our virus, which has GP120 on its surface, these are the envelope proteins, and GP41, which is lying behind it. GP120 binds to the CD4 receptor on the T cell. Then it requires two co-receptors, which are either CCR5 or CXCR4. Once these co-receptors bind to GP120, it undergoes a conformational change, exposing a specific site on GP41, which then mediates the fusion of the envelope with the host cell and helps the virus to then enter. So first, it just GP120, which has to bind to the receptor. Only later, GP41 will get into its action. Which of the following diseases is not transmitted by the vector shown in the image below? So here we can see this is the hard shell, also called as the scutum on the surface of this insect. So this is hard tick. Identifying vectors is very, very important. Hard tick, soft tick, body louse, sugars, rat flea, etc. These are very, very important. So which of them is not transmitted via hard ticks? Listeria, yes. Babesia, yes. Orientia is transmitted by sugars of trombiculid mite. And Crimean Congo hemorrhagic fever, yes, it is transmitted by hard tick. Our answer to this is Orientia. Okay, this is an image which is comparing hard tick with soft tick. It's pretty obvious. This is the hard shell on the surface. This is the soft tick. Remember, soft tick is the vector for relapsing fever. Relapsing fever. Rest, most of the tick-transmitted diseases are via hard tick. A quick enumeration of these important diseases. Babesia, Ehrlichiosis, Lyme's disease, spotted fever rickettsiosis, tularemia. Okay, so we have one protozoa, then we have the following bacterial diseases, then we have certain viruses, though there are many more, but I want you to remember one, KFT, the other one is Crimean Congo hemorrhagic fever, then Russian spring summer encephalitis virus. Okay, then we have cold T virus, though it is not reported from India, it's mainly reported from US. So KFDs, Crimean Congo, these are reported from India. So you must remember that these are transmitted via hard ticks. A 19-year-old boy from a rural area presents with a 12-day history of altered mental status, decreased vision, ataxia, multiple cranial nerve palsies, and hemiplegia. The electron microscopic image of the organism is given below. What is the likely organism? Okay, so we have a patient most likely to be suffering with encephalitis, and they have shown us this electron microscopic image. Okay, these are the pseudopodia. So you can read the options. All of them are the free-living amoebae. Free-living amoebae, which are found in soil and water. Okay, so we have to choose the answer. Looking at the electron microscopic figure, you can see these spiny pseudopodia. Spiny pseudopodia, which are known as acanthopodia. So obviously, what is our answer? This is acanthamoeba. Okay, it's specifically to be remembered that acanthamoeba has spiny pseudopodia. These are the spine-like structures you can see. Okay, and that's how we can get infection with acanthamoeba, which causes granulomatous amoebic encephalitis. Okay, this infection mainly occurs in immunodeficient individuals or debilitated individuals. Though it was not mentioned, I don't know, these are recall questions. So I don't know whether this child had some immunocompromised state or not. But ideally, this is causing in immunocompromised or debilitated patients. Okay, and the second condition it causes is keratitis. Okay, so there are two stages in the life cycle of acanthamoeba: cysts and these trophozoites, which have those spiny pseudopodia. Either of them can cause the infection, and the infection can occur either through the eye when it causes keratitis, or it can be inhaled when it reaches the lower respiratory tract and then spreads via the blood to cause granulomatous amoebic encephalitis, or sometimes it can be even acquired through the skin when it again can cause granulomatous amoebic encephalitis. Which of the following viruses has the least teratogenic effect? Least teratogenic effect. So congenital malformations would be least likely to be seen with herpes simplex virus 2. The rest of them lead to massive teratogenous effects on the fetus. Okay. So herpes simplex virus, more often we remember it as causing neonatal herpes when the child gets delivered through the infected maternal tract. But in about 5% of cases, the fetus can get infected via the virus getting transferred across the placenta. In that case, that would be causing an in utero HSV infection and then can cause teratogenous effect on the baby in the form of microphthalmia, microcephaly, and the child can have skin lesions. But more often, the others are pretty famous, causing cytomegalic inclusion disease caused by cytomegalovirus, the most common virus transmitted across the placenta, which causes microcephaly, periventricular calcifications, deafness, chorioretinitis, mental retardation, jaundice, petechial lesions, hepatosplenomegaly, and so on. Okay. And congenital varicella syndrome, when the mother has chickenpox infection in the first half of her pregnancy, it can lead to hypoplastic limbs, CNS defects, microcephaly, cicatrizing skin lesions, and chorioretinitis and cataracts. Okay. And finally, congenital rubella syndrome, the characteristic triad CDC, congenital heart defects, patent ductus arteriosus, pulmonic stenosis, deafness, and cataracts. That's how I remembered in my undergraduate days, Center of Disease Control, CDC, along with microcephaly. Okay. Which of the following statements are advantages of the saline mount over the iodine mount? Now, this was an absolutely new question. Advantage of the saline wet mount of the stool. Sorry, this should have been mentioned, of the stool sample. One, demonstration of motility of trophozoites, identification of the internal structures of the cysts, differentiation between the bile and the non-bile stained eggs. Okay, here we have been asked the advantage of the saline mount over the iodine mount. Okay, so one, yes, we can demonstrate the motility of the trophozoite in a saline mount, but when we use an iodine mount, the trophozoites are absolutely immobilized. Okay, so that is an advantage, yes. Identification of the internal structures of the cysts are better seen with an iodine mount in comparison to a saline mount. Okay, so this is not our answer in this. At differentiation between bile stained and non-bile stained eggs, even that is an advantage of the saline mount. We have two kinds of eggs seen in the stool, bile and non-bile stained. In a saline mount, the non-bile stained eggs would have a transparent shell, whereas the non-bile stained ones would have brown appearance. But in an iodine mount, both bile and non-bile stained eggs would be appearing brown in color. Okay, so our answer to this is option B. 1 and 3 are the advantages of saline over iodine mount. In which of the following organisms the genetic material is adenine not equal to thymine? Okay, so adenine, generally we know in DNA, what does it pair with? It always pairs with thymine. Okay, in RNA, we don't have thymine, we have uracil instead. So this question is an indirect way of asking which of them has the genetic material as RNA, not DNA. Okay, herpes viruses are DNA viruses. The adenine is going to pair with thymine, so obviously both of them are going to be equal. E. coli has a DNA genome. Again, it's going to be equal. Human mitochondrial cells contain the genetic material as DNA. Again, they will have adenine equal to thymine. HIV has an RNA genome. Here there will be no thymine, there will be uracil instead. So that is our answer. Last question. Which of the following is a biosafety level 3 infection? XDR tuberculosis, Ebola virus, Salmonella typhi, Crimean Congo hemorrhagic fever. Okay, any kind of tuberculosis, normal TB, MDR TB, XDR TB, the cultures are to be handled in taking it as a BSL-3 pathogen. So that is definitely our answer. Ebola virus is a BSL-4 pathogen. Salmonella typhi is a BSL-2 pathogen. Crimean Congo hemorrhagic fever is a BSL-4 pathogen. So all pathogens which are handled in the microbiology labs have been classified into 4 biosafety levels. It is a guideline for the microbiologists to be handling the cultures taking specific precautions. So this is what has been asked. BSL-3-1 means this is an agent which has minimal hazards to the laboratory and to the community, meaning when this laboratory workers moves out into the community. So pathogens these are non-pathogenic organisms like Micrococcus or Bacillus subtilis. BSL-2 are those which are moderate risk to the laboratory and to the community. And these include organisms which are normally we study about Vibrio cholerae, Meningococcus, Staph aureus, or MRSA, or hepatitis virus, HIV, dengue, Vibrio, etc. Okay. BSL-3 are having serious hazards and can cause potentially lethal condition to the laboratory as well as to community via respiratory transmission. So here we have Mycobacterium tuberculosis, Bacillus anthracis, Coxiella burnetii, Chlamydia psittaci, or Rickettsia rickettsii, West Nile virus, the encephalitis-causing viruses like Eastern equine, St. Louis encephalitis, SARS virus, yellow fever virus, pandemic strains of influenza, coccidioides, histoplasma, leishmania, donovani. Okay. And finally, in PSL-4, these have high risk of aerosol transmission, and therefore there is no vaccine or therapy that is available. So they are categorized as BSL-4. And remember, we have only viruses in BSL-4. These include Ebola, Marburg, variola virus, Crimean Congo hemorrhagic fever virus, or Rift Valley fever virus. Okay. Right. So this brings us to the end of our questions in microbiology of the INI-CET November 23. Bye-bye.